So, the state of happiness is directly proportional to the gap between what you have promised and what you have delivered. So, as long as, take care of that. The wrong choice of a patient, wrong choice of a lens, inadequate amount of counseling, and poor quality of surgery are all the reasons for, unhappiness. So, it again tells you the age-old thing, chair time spent before the surgery is more crucial than the time spent after. See, never overpromise and underperform. Patients after retinal surgeries are happy with 660 vision. So all of us know that because they expect that much. All our ECC patients in the past were happy using glasses. Now compare them with today's 6 unhappy patients. Unhappiness with monofocals is rare. If it happens, it's always due to misinformation or lack of information. Like very often they come and tell you, Doctor Sahab, lens डाल लेकिन कुछ नज़दीक का नहीं दिख रहा. And then you tell them, look, you're not supposed to see that because your lens doesn't have that power. And unhappiness with multifocals used to be common until some time back, but today it's not. And there are several reasons why. It's always due to a tall promise and poor counseling. Now, percentage of unhappy multifocal patients is reducing primarily because today we have better understanding how these lenses function differently, better quality of lenses. When you say better quality of lenses, Mohan Rajan, I remember you talking about Resume. Yeah. But Resume used to be one of the finest lenses.
Very good lens.
And patients could come years later. So this neural adaptability is something that you really can't define.
You can't do anything about. Even today, you can't do anything about.
And of course, the better counseling and more realistic expectation from the lens. And I still feel, Arup, today when I or you counsel a patient, we have better confidence in that lens. So it comes into your body language. So finally, it goes with the body language. When you say yes, you go for that. At the same time, you tell me you'll have all these problems, but still I'm advising you because for the convenience, it may not be as sharp as monofocal. That's what we always tell. But the sheer convenience that you're looking for, then this is the lens. So why are the patients unhappy? See, these are the only reasons. The distant vision less than expected. Distant vision is waxy. Now that's a very serious problem. Reading vision less than expected, inability to read in poor light, poor intermediate vision, dark shadows in the temporal field, glare and halos, and poor night vision. Now there cannot be any more reason than this. Now let's analyze the causes. It could be workup related, it could be eligibility related, technique related, technology related, and personality and counseling related. Now workup related. Now detailed workup, like it was said by Dr. Sai very nicely, that's where we know that today our understanding of the level of workup that we need to do for a multifocal as against monofocal, we'll just tell you what all it is. Now regular cornea with a clear 6/6 potential with eye trace and other such aberrometers, we know about the visual angles, and if you have a visual angle like angle alpha, angle kappa, which are more than the stipulated range, probably that patient is never going to be fine. Like I can just tell you, today when we use Varion or Callisto, and at the end of the surgery, you just check the centration, you check the overlap, and if that centration is well within range and the visual axis is well within range, then you're so confident that even in the post-op period, patient says, Doctor, I'm not happy, you can very confidently tell him, you wait for some time, you're going to be all right. Now, I have a patient, trifocal toric lens. He waited for 2 months for that lens to come. I put it. He said, Doctor, I'm very happy because he was a high myo. I had never seen that good before. But I still need. But I knew that it was perfectly done surgery. His A-scan biometry was perfect. I said, look, just be rest assured. Give me 1 month time and you'll be fine. And he was. See, that confidence you get because of all these machines, because they tell you right at the end of the surgery, yes, this patient has to do well, something like that. Now, healthy 6/6 macula and other chronic degenerative disease, which are, if they're ruled out, then those are the things that you do. Now, what is it, the technique related? Now, consistent reproducible results, minimal trauma with minimal induced astigmatism, and a centrally placed lens in the bag with minimal decentration. Now, technology related, appropriate lens which matches to the requirements, a mix and match approach wherever necessary, and post-op touch-up when post-op refraction is out of acceptable range. Now, when I put a multifocal, I should be prepared that tomorrow if he gets a refractive surprise, without charging him much, I must be able to do a touch-up. Now, touch-up could be because of in terms of PRK, LASIK, or it could be LRI. And if God forbid he's got a big refractive error, I may have to add on lenses. See, these days we have such lovely add-on lenses. We can, in fact, there are instances where if the patient has dysphotopsia and he cannot get over it, you may even put a add-on lens with a zero power, larger lens with a circular border, round border, and the patient might do better. Arthat, I don't know much, but Arup can definitely counsel on that because he always attends international forum and he discusses. Because we don't have that dysphotopsia problem as much as Westerners have. Now,
What is referred to as a piggyback lens.
huh?
There are many ways of tackling negative dysphotopsia. One of them is
Just put on it.
there are various.
Take this, ma.
You can
It's
give.
also not working.
So there are various ways of tackling negative dysphotopsia, particularly in a multifocal lens. In a piggybacking a zero power lens, in case your brand one target is a good option. I think it works between 85% to 90% of the cases. Other options are the bezel and your capsular.
Capture.
And not for multifocal lens, capsulation, and not for multifocal cases, but monofocal cases. Bezel amputation of the bezel optic, that is also helped.
Nasal optic.
Bezel optic.
The lens will not decenter?
Optic, not the haptic.
Optic.
And finally, of course, IOL exchange has to be done if the patient is so miserable.
What about the reverse optic capture? You can do that, no?
Yeah, reverse optic capture.
Bring the optic up.
So reverse optic capture, the problem is when you do it on the fellow eye. See, one eye has negative dysphotopsia, so fellow eye there is high incidence of posterior capsular opacification because you don't have that contact between the posterior surface of the lens and the capsule. But it's a very controversial subject, and only solution for that is IOL exchange with a non-multifocal monofocal lens of appropriate. There's a big topic.
What monofocal lens? Again, multi-piece
I think the lens that works best in this situation is silicon lens.
silicon lens.
Round border, round edge. Thank you. Now, personality and counseling related, several of the problems experienced after the surgery will not occur if adequate time is spent in discussions prior to surgery. Assess the patient's character, lifestyle, and expectation, and if never promise full spectacle independence, there's a good chance that you may not have to use glasses often, but that's all that you promise, and not the freedom of glasses. Now, post-operative discussion would be second blurred image. A simultaneous perception of distance and near vision results in second blurred image, which patients need to learn to ignore, and this counseling has to be done before the surgery. Poor intermediate vision. Now, bifocals will require glasses for computer use or need to get computer closer. Now, this is again part of the counseling that you do before. Halos, patient needs to know in advance that all the diffractive lenses will produce halos. Reading vision, poor in low light, not very good with most of the multifocals. They need to be reminded that they were told to this before. For short periods, use a flashlight of a mobile whenever they want to read in a dim restaurant. And for extended reading, using a good halogen or LED lights or a small reading pad would be something that's a solution. Early and seemingly minimal posterior capsular changes can lead to early loss of reading vision. So wide capsulotomy, sometimes much earlier than what a monofocal would need. With regards to poor intermediate vision, it's a concern related to use of computers. Bifocals with lower ads gives good results, or trifocals can be used. If a laptop is to be used, then this can generally be brought closer into the reading distance. In case of a desktop computer, it may be more difficult, so use a pair of 1.5 diopters of glasses. Now, dark shadows of flickering of light in the temporal field, usually they disappear with time after the anterior capsular edge opacification or the patient adults, but this is a very controversial thing. With regards to cornea, it's a weak link in the visual system, especially in a presbyopic practice. Anterior segment variations like corneal steepness, chamber depth, and pupil dynamics are all taking part in addition to other known factors in the performance of a presbyopic lens functioning. There has to be strict protocol for corneal normalcy. Presbyopic lenses demand a higher degree of corneal regularity in order to achieve proper functioning. Some mild corneal irregularities that would not affect the performance of a monofocal lens may now in fact create noticeable problems with multifocal lenses. In an unhappy patient, post-operatively, rigid gas permeable lens can be used to see if the cornea is a culprit. After putting a rigid PMMA lens, if most of the problems go, then you know the culprit is a cornea. Treatment. Do not consider any action for at least 6 months. So what do you do for 6 months? Make friends with him. Use a lens in the second eye which has less effect on the distant vision. Lubricants for abnormal tear film breakup and Schirmer's test monitoring. Glasses for occasional use. Surgically, exam laser, piggyback and toric lens adjustments are some of the options. Due to incorrect IOL power selection, limitation of IOL power calculation formulas, in extreme emmetropia or IOL positional errors, you can manage them either with LASIK, IOL exchange or a piggyback. PC opacification will occur early. Blurred vision and increased photic phenomenon higher in hydrogel or round edge lenses, which is not an issue today. Lower rates in IOL placed in the bag than sulcus. Management would be AIOC capsulotomy early. The question of multifocal IOL explantation and exchange, its most common cause in the descending order. If the IOL is dislocated, the refractive error issue is there, IOL has opacified, or neuroadaptation has not occurred. And the main objective reasons would be decreased contrast sensitivity, photic phenomenon, unknown origin, neuroadaptation failure, incorrect lens power. See, this is in order of the reasons why a multifocal patient would come asking for explantation. So in conclusion, if the patient's unhappiness is due to omission on my part, then the onus is on me till the patient's satisfaction is restored. And how do you manage it? Give him time, make friends with him, have coffee with him and share in his pain and distress. Make your intention to help him sincere, genuine and visible, and be prepared to receive all the brickbats. What matters in the end is less complaining patient. Thank you so much.